on.
Good afternoon, sir. My name is Gary. I'll be your nurse today. Before we get started, I'm going to go ahead and check your name and date of birth. Okay. Mr. Amy Patient. The doctor's ordered a nasogastric tube. Basically, it's a tube that's going to go in your nose, down your throat, and into your stomach, and it's going to relieve some of this nausea that you've been having and help make your care a little bit better and easier. Before we get started, I'll go ahead and provide privacy by closing the door curtain, and I'll perform hand hygiene. Might as well go ahead and do it for real. Now, the next thing I'm going to do is go ahead and raise the bed to an appropriate working height to allow for proper body mechanics, and raise the head of the bed to the high Fowler's position, or 60 degrees. 60 to 90 degrees. After I've done that, I'll go ahead and lower the bed rail in order to make access to the patient just a little bit easier. I need to just go through my equipment, make sure I've got everything I need. I'll start preparing my tape. I need about 3 pieces, one for the tape it to the cheek, one to tape it to their clothing, and one to actually tape it to their nose. So I'll go ahead and put my tear in the one for their nose. You think I'm talking loud enough? Loud enough? So I've got all the equipment that I need here, and it's all laid out and ready to go. So I'll go ahead and put my gloves on. This is not a sterile procedure, so I don't need sterile gloves, but it is a clean technique. So of course, gloves would be necessary for it. The next thing I'm going to do is just verify which nair I'm going to put the tube in. I can do this by asking the patient if they've ever had a nasogastric tube in. Sir, have you had a tube in your nose before? He says no, so the next way I can verify this is by having them blow out each nostril while I occlude the other one. Blow, blow. In this case, both his nostrils are good, so I'll go ahead and use the one nearest to me. So the next thing I'm going to want to do is I'm going to verify the length of the tube before I go ahead and put all the linen protector and everything down. That way I can visualize the xiphoid process just a little bit better. I'll go from the tip of the nose to the ear, and of course to the xiphoid process. This is right around 60 centimeters on here, but I still need to mark it with my tape. And this is going to let me know whenever I reach the appropriate depth with the tube, so I don't go too far and irritate the gastric mucosa. Once I've done this, I'm going to go ahead and promote flexibility of the distal end of the tube by wrapping it around my finger. And at this point, I'll go ahead and put this plug on there. That way when I go to insert the tube, no gastric contents come out spontaneously. So now I'm ready to put the linen protector back on the patient, so that if he does feel the need or urge to vomit, then his linen will be protected and we won't have to bother him with changing the linen. I'll give the emesis basin and a cup to the patient to hold in each hand, and I'll instruct him that the cup's full of water is going to be for inserting the tube a little farther. One thing I definitely need is lubrication right here, but let me just stop and make sure. I think I'm ready for insertion. So I'll go ahead and lubricate the tip, just for allow ease for insertion. And I'll tell him to go ahead and extend his head back while I put it into his nair. So I'll go ahead and insert it into his nair, and once I get past the throat, I'll go ahead and ask him to lean his head forward and take his glass of water, or his cup of water, and take swallows as I insert the tube. Swallow, swallow. If there was any respiratory distress at any time, I would go ahead and remove the tube immediately, because that means I'm probably going into the lungs. In this case, this is about as far as I can go in this dummy, but of course in real life I would make sure and go all the way to the tape. Oh, here, it's going a little further now. In any case, I'll go ahead and temporarily secure this to the patient's cheek once I reach my mark on the tube. And I need to do this temporarily so that I can verify placement. There are three ways that I'm going to verify placement. I'm going to ask the patient to speak, so can you say your name again for me, sir? The next way is I'll visualize the back of the throat, the back of the oropharynx, and just see if I see the tube coiled up or anything in the back of the throat. If I don't, then I can be reasonably certain that it's not in the coiled up in the back of the throat anyway. And then the next way I need to verify placement is to aspirate a little bit of the gastric content. Of course, I'll kink the hose when I do it so that no fluid comes out once I take the stopper off, and I'll just pull out just enough to check the pH. Whenever I do pull out the gastric contents, I need to note the quality and the character of the contents that I've got. Normally you expect them to be probably green, maybe yellow. It depends really on how sick they are, how much maybe they've thrown up in the past. Once I get the gastric contents, I'll go ahead and check the pH of them. I'm looking for a value between 0 and 4. If I do have that value, and we'll just say I have 1 here, if I do have that very acidic value, I can be, again, fairly certain, to the best of my nursing abilities anyway, that I have the tube in the appropriate place. And since I did get a value of 1, I'll be ready to go ahead and secure the tube a little bit more securely. So the way I'm going to do this, I've got this piece of tape I've already torn. I'm going to wrap one around, in this case clockwise. And I'll wrap the other around the other way. In this case, it's going to be counterclockwise. So once I've done that, the tube's fairly secure, but this probably would work to secure it to their clothing, but since this is a little higher up, I'll just get another piece of tape. But I will secure it to their clothing. That way when they're going to the x-ray department, or in the meantime, it doesn't fall off and snatch the tube out the throat, because if it was me, I'd be pretty upset if I had to go through this procedure again for no good reason. So I'll secure it to their clothing and make sure the rest of the tube's up here and in place. And at this point, I'll be ready to start cleaning up my equipment. So I clean up everything I have. Like I said, he's going to go to the x-ray department, and I won't need this until I go to take the tube out, which will be, pending on doctor's orders. One thing that's very important, or several things that are very important to do, I raise the bed rail back up, because again, we don't know when the x-ray department is going to come back and pick him up. And I'll lower the bed to the lowermost position and lower the head of the bed to 30 degrees. I'll go ahead and take my gloves off and perform hand hygiene. And at this point, I want to go ahead and document which nair I used, the size of the tube, the quality, character, and pH of the gastric contents that I aspirated, and also what the tube's going to be used for. And depending on the facility you work at, there may be more documentation you need to do. But at this point, I'll be done with that particular insertion. So I'll come out, he's going to go to the x-ray department, and I come back. Good afternoon, sir. My name's Gary. May I ask you your name and date of birth? Excellent. So I verified the patient, so the next thing I'm going to do is explain the procedure. The doctor's ordered the removal of your nasogastric tube. This is good news. It means that your condition's improving and we can finally allow you to get fluids on your own. So it's not going to be nearly as uncomfortable as it was to put it in, and hopefully we can get this out of the way as quickly as possible for you. I'm going to go ahead and perform hand hygiene, and I'm going to provide privacy. And the next thing I'm going to do is get my equipment ready. I don't need any tape for this particular procedure. but I will still use my linen protector. I don't really need to lower the bed rail for this. It's not in my way in this particular case, but I would raise the bed to an appropriate working height. And the head of the bed's fine at this position for, again, this removal. But I'll go ahead and get my material ready. I'm going to go ahead and give him his Mises basin. And at this point, I'm going to go ahead and put gloves on. So what I want to do, I want to turn off the suctioning device. I want to disconnect the tube from the suctioning device so that whenever I do take this tube out of his nose, I'll be able to go ahead and immediately discard it into the red biohazard bag. Before I do that though, I need to go ahead and get my Kleenex. I'll instruct the patient that he needs to hold his breath whenever I pull the tube out for the entire time that I am pulling it out, maybe take up to 10 seconds. So sir, go ahead and hold your breath. Hold it. Again, I'm going to discard this immediately into the red biohazard bag. And at this point, I'll grab another tissue. And go ahead and clean their nose up. And offer them a warm, wet washcloth in order to maybe soothe their nose. If the tube has been in for a while, they'll want to do that. So at this point, I can go ahead and start cleaning up. I'm going to take my gloves off and perform hand hygiene. And at this point, again, I've already cleaned up all my materials, so I'll go ahead and lower the bed to the lowermost position, as always. Lower the head of the bed to a comfortable position for the patient. And, of course, I'll put the call light within reach of the patient and make sure that he knows exactly how to use it and that he can call at any time if he needs anything. And at this point, I'm ready to do my documentation. I'll need to note how the patient tolerated the procedure. If there were any contents in the suctioning device, I may want to note the amount and the quality of those contents. I'll need to note if the tube was intact or not, and I'll also need to note basically just the patient's condition upon receiving the procedure. And depending on your institution, there may be more or less documentation to make. And at this point, I'm done.